So good evening, everyone. Welcome to the Surgical Coaching Summit, Navigating Change. I'm Dr. Sudha Pavluri-Kwame, a health services researcher and scientist at the University of Wisconsin-Madison Department of Surgery and co-founder of the Academy for Surgical Coaching. I'm honored to be your host this evening. This summit brings together leaders in surgical education and innovation to explore how coaching methodologies can help us navigate the evolving landscape of surgical practice. Throughout the next 90 minutes, we'll examine different facets of change in surgery and explore how coaching can provide a framework for continuous growth and excellence. Before we dive into our program, I'd like to extend our sincere gratitude to our sponsors who have made this summit possible. First, a special thank you to Caveris, our gold sponsor. We're delighted to have their Executive Director, Dan Houghton, and other members of the Caveris team joining us today. Thank you also to Siemens Healthineers, our silver sponsor, for their support of this summit. We also want to thank the sponsors of our industry panel, Care Syntax, Leantas, Proximy, Theater, and Vidvio. Representatives of these organizations will be joining us for an important discussion about utilizing data to facilitate performance improvement. Thank you to all of our sponsors for your generous support and commitment to advancing surgical coaching. Your partnership is instrumental to our mission and the success of this summit. Full profiles of all of our presenters will be available in the chat. And if you have questions, please enter them into the chat and they'll be addressed by our presenters and colleagues. So just let's quickly review our agenda for today. We'll begin with Dr. Magdy Milad, speaking on the intersection of improv techniques and surgical coaching. Next, Dr. Kara King will address surgical practice readiness, followed by Dr. Caprice Greenberg and Dr. King co-moderating our industry panel on utilizing data for performance improvement. And finally, Dr. Christine Lombardozzi will lead an interactive exercise on navigating career changes for surgeons. So let's get started. It's my pleasure to introduce you to our first speaker, Dr. Magdy Milad. Dr. Milad is the Albert B. Gerby Professor of Obstetrics and Gynecology at Northwestern University Feinberg School of Medicine and Chief of Minimally Invasive Gynecologic Surgery at Northwestern Medicine. He's also a surgical coach and improv performer. Dr. Milad will share a unique perspective on how the practices of improv and surgical coaching converge to advance individualized learning and surgical skill development. Please join me in welcoming Dr. Magdy Milad.
Hello, thank you. Can you hear me okay? And do you see my slides? Okay, wonderful.
Yes.
Well, thank you for the lovely introduction and for including me in this program. Just a quick housekeeping note. I may ask you at the end of my presentation to turn your cameras on for a group activity, so just a heads up. Let me share a story about my daughter, Mary. She was worried about being bored during the winter break as a freshman, and trying to be a good dad, I offered to pay for an improv class at Second City, a training center that you might be familiar with for actors and actresses and comedians. Unfortunately, she had to back out at the last minute. So I called Second City. I asked for a refund. Should be no big deal. But they told me they don't really do that. But the tuition is transferable. So here I was faced with a decision: either lose the $327 or take the class myself with about 24 Gen Zers. Yeah, it was close. It was really close. But there I was in class, and I had a lot of fun. I developed friendships with young people. I learned about their subculture, and I kind of learned how to play again. And of course, obviously, I learned how to improvise. Now, improv is not the same as Saturday Night Live. It's not sketch played out like a play. Improv takes a prompt from the audience and sets a scene, or a set of scenes, actually, based on a suggestion. You might have seen Whose Line Is It Anyway? That's called short form improv. It's a little like that, but you actually play out an entire 3-act story based on a single suggestion. That's called long form improv. It's also known as the Herald, although no one really knows why it's called that. Nick Napier, a improvisational expert, says that it's the art of not knowing what you're going to say or do and be completely okay with it. You just kind of make stuff up. And what I started, as it started as fun, it really became much more in ways I didn't anticipate. The more I got into it, the more palpable changes were occurring in my life. I was interacting with patients differently, residents differently, even my family differently. I was more responsive, I had better eye contact, and I just got more out of interactions than I did before. And then when I took the Academy for Surgical Coaching training course, I noticed so many parallels with doing improv that I just had to share it. Well, it should come as no surprise that there are some rules to improv. They're not really to restrict creativity, actually just the opposite, it's to enhance it. These rules are out there to facilitate collaboration and build trust and create a safe place for exploration and the basic structure for the natural story to arc. Well, these are all very familiar to surgical coaches. As a coach, we don't dictate the learning opportunities, nor do we share how we would do it. After establishing a collaborative and trusting relationship, we create a safe place for exploration, and we allow the coachee to literally set the stage and explore those learning opportunities and goals that they have set themselves. Okay, so what are some of the rules? Well, obviously the most important rule in improv is the yes and philosophy. If you're doing a scene and you respond to your partner's suggestion with a no, you can't possibly develop momentum. An example would be, let's say, the suggestion is let's have a picnic. And my scene partner responds with no, because the weather is bad. Well, that scene just fell flat, right? Instead, each improv member responds with yes ands to the previous suggestion. So to the prompt, let's have a picnic, the response might be, yeah, and let's bring a guitar. And yes, and invite Taylor Swift. And yes, and let's have it under the Eiffel Tower. You can see how the momentum just grows and grows. Well, just as an improv actor, surgical coaches must also remain open to learning goals of the surgeon and not the coach. As a surgical coach, we avoid discouraging our coachee. We're not there to make them feel bad by saying no because. We're there to develop a safe space. And like improv, we have their back, supporting them through the journey. To just digress briefly, but importantly, history is filled with amazing doctors who were told no because. They weren't just actively discouraged, they were like ridiculed. And in the end, they were actually vindicated. Just a couple of examples. Dr. Ignaz Semmelweis, a physician who was ridiculed for the idea that is now common sense. He was a Hungarian physician in the mid-19th century, and he noticed that puerperal fever, which was contagious, was being passed from student and physician to new mothers. So after advocating for washing their hands, the puerperal fever mortality rate dropped by 90% in 6 months. Well, that was 1847. It wasn't until 1975 that the CDC published guidelines on hand washing in hospitals. And poor Dr. Semmelweis, having been told no because all his life, Semmelweis became increasingly despondent, was admitted against his will to an insane asylum, and was severely beaten, died 2 weeks later. Or Dr. Crumpler, the first Black woman to complete medical school, faced enormous challenges being told no because of race and sex, despite being a brilliant physician. She wrote the book that preceded What to Expect When You're Expecting. Or Bovie, the linchpin to electrosurgery, who was told no because only a charlatan would use electricity in the operating room. I mean, you can't believe it, right? He sold his patent for $1 and died a penniless man. Or Kurt Sem, the chair of OBGYN at the University of Kiel in Germany, the father of laparoscopic surgery, was told no because only a person with brain damage would perform laparoscopic surgery. He literally had to undergo a CT of the head to demonstrate his sanity. These obviously are not the only examples. Unfortunately, medicine is filled with it. So let's avoid the no because, and let's stick with the yes and. Okay, well, back to improv. A central tenet of performing improv is living truthfully. That means being fully in the moment. You can only build something with the scene partners by being completely immersed in what's going on. You've got to listen intently. You've got to respond authentically. This is also true about surgical coaching. You can't really prepare. You wait for your coachee to finish their sentence, and you respond and you take on that new direction. Expect the unexpected and be ready to adapt. You have to be able to respond to whatever comes your way. Situational awareness is key and helps to build a shared mental model, allowing exploration of those details that are so important. Who was in the room, what each person was doing, where they were standing, and why were they so focused. All of these become important. Living truthfully is about presence, adaptability, and responsiveness. In improv, we practice deep listening, not just listening, not just hearing our colleagues' words, but fully absorbing the tone, intent, the nuance, and even the nonverbal cues. It's critical to have presence, to give your full attention, free from distractions and inner dialogue, non-judgmental, to listen without interruption, and not without planning a response. Curiosity, staying open and asking questions that deepen understanding rather than steer the conversation, and reflection by paraphrasing what you just heard to confirm understanding. This creates a foundation for guided inquiry where questions and responses build the narrative without forcing a predetermined outcome. And improv, you're there to support your teammate. There's no judgment. We create an area of trust, allowing for natural exploration of vulnerabilities and growth. Well, specificity is absolutely the key to making a scene resonate. Imagine if I start a scene with, "This is the third pineapple I've carved today." How much richer would that be than to say, "Well, I did something weird today"? Instantly, you already have a vivid picture of the scene that's grounded. Well, similar with coaching. Listening and inquiring about the specifics deepens both understanding and connection. For example, if a coachee says, "I struggled with completing the second wrap of a laparoscopic surgeon's knot," this is much more specific and helpful than "I couldn't tie a knot." One really important opportunity is also to listen for the unusual thing. I can't underestimate this. I'll give you an example. I had a patient who came to see me about 2 years ago with symptomatic fibroids and clearly wanted to move forward with surgery, but was lost to follow-up. Well, last month she came in and I asked her where she had been for the past 2 years, and she said that she had been distracted. Well, I could have let it go, right? But that was kind of an unusual thing. I mean, what a strange thing to say that I was distracted. So I asked her to tell me more. Well, she went on to tell me that just after the consult 2 years ago, she was on a beach in a sleepy lakeside resort in Western Michigan, and there was a shooter on the pier. Now, I've been on that pier and I've been on that beach. I know exactly where she was. She was sitting next to her friend. Her friend actually got injured by the shooter, and she spent the last 2 years looking after her. If I hadn't asked about that unusual thing, I would not have had the same deep understanding and connection. Instead, I probably would have written a story in my head, right, about how she maybe didn't take her healthcare seriously or was looking for other opinions or the fibroids really weren't bothering her that much. It was critical to follow up on that unusual thing to deepen the connection. Okay, and then finally, one of the most important things I learned from improv is how to mentally cope with mistakes. We have all been there. We should have reviewed the pre-op imaging. We could have talked to the patient about the undesired outcome beforehand in more detail. We shouldn't have let the resident do something. We should have, couldn't have, didn't. No one likes to admit a mistake, despite it being an amazing opportunity to learn from it and be better as a result of it. Bobby Jones, the golfer, said he never learned from a game he won, obviously only from the games he lost, right? Learning from our mistakes is the only way to get better. And that's why to get a surgical coach. But we get all caught up in the mistake, right? We allow it to diminish our effectiveness. Imposter syndrome sets in. And there's this vicious cycle that goes on and on, gnawing away at us. This is what happens to all of us, to improvisers, to coaches, and even to seasoned coaches and surgeons. How do we bounce back and learn from mistakes when we're physically sickened by them? Well, I'd like to invite you to demonstrate the technique. And this does require a minimal amount of physical activity, not much though. So I invite you to turn your cameras on, and I want you to stand up. I know, it's a lot to ask, but yes and me, and stand up if you're able, like really, like stand up. And this is called the failure bow. Admittedly, it's a little strong to call it failure, but nevertheless, that's what it's called. Last time you were at the circus, you may have seen it because trapeze artists and acrobats and improvisers are all trained in the technique. So this is how the technique goes. Instead of cringing when you make a mistake and letting those negative thoughts haunt you and gnaw at you and make you less effective, you raise your arms in the air as if to announce, I made a mistake. Take a bow, and then you move on. The failure bow can be transformative because it alters your physiologic response to failure by removing those demons of self-doubt and self-judgment. Without holding us back, we can learn. So let's do this all together. Hopefully you're all standing up. Those cameras are on. Okay, think about a time when you really screwed up, or maybe like nearly screwed up. And I want you to get into that cringe mode. Okay, so this is how it looks. Shoulders are hunched, head is down, arms are crossed, maybe even your eyes are closed. I want you to just dwell for a moment on that near miss or that catastrophe or that near catastrophe, the failure. Now just like let it go. Take a deep breath, stand tall, arms in the air, okay? And take a deep bow and applaud. And with that, thank you for having me. I look forward to the rest of the program. Thanks again.
Thank you, Dr. Milad, for that fascinating perspective on how improv principles can enhance surgical coaching. Your concepts provided a powerful framework for adaptive learning and skill development in the surgical space. So thank you very much. We will now transition to a critical challenge in surgical education, practice readiness. To guide us through this discussion, I'm pleased to introduce Dr. Kara King. Dr. King serves as section head of minimally invasive gynecologic surgery and medical gynecology at Cleveland Clinic. She's also the program director for the fellowship in MIGS and director of innovation at the Women's Health Institute. In addition to these roles, Dr. King serves as president of the Academy for Surgical Coaching, bringing her considerable clinical expertise to the advancement of coaching methodologies. Dr. King will be focusing on how surgical coaching can accelerate practice readiness for fellows and new to practice surgeons. Please welcome Dr. Kara King.
Thank you so much, everyone. Sudha, thanks for that kind introduction. Magdy, that was incredible. Like, you have been my mentor and sponsor forever, and you still never cease to amaze me with your creativity. Like, that was incredible. So thank you so much for that. I loved it. All right, so I'm going to talk about the readiness crisis, and this is something that really transcends all subspecialties. You know, as I kind of dove into the general surgery literature and the subspecialist literature within surgery and OBGYN, it's something that really transcends all specialties. I'd love to have people's thoughts and comments in the chat as I go. It's not distracting at all, so feel free to comment on anything that comes up during these slides. All right, so as I put these slides together, but also just like in my everyday life, yeah. So like I said, I'm program director of our fellowship, so I'm with our fellows a lot, and I also operate with residents all the time and medical students all the time. And it's really made me think, like, what does it actually mean to be ready? Like, what is this like ready, the title that we give people? Is it logging so many procedures, like after 100 hysterectomies or after 50 appendectomies? Is that considered ready? Is it feeling calm during complications? Is it being able to evaluate a patient in the emergency room correctly and know when to bring them back? Like, what does that actually mean? And then what if I told you that we've actually created a system where graduation of our residents doesn't actually mean readiness? Like, graduation doesn't always mean that they're ready to practice. And what does that mean for us as educators? What does that mean for us as patients moving forward in our lives as we get older? I'm thinking about this. And so I'd love to pose some of these thoughts and questions throughout the next few minutes. So the question really is, again, what is readiness? And when I break this down, I'm really thinking about different areas. So technical skill is one part of being ready, I would think, as a surgeon, right? You have to be able to do the things surgically to keep the patient safe. But there's also this element of decision making, both in the operating room, so decision making when you're there, but also like in the clinic, who do I actually bring to the operating room? So decision making. You have to be able to manage complications. So maybe you know what to do when your bandwidth isn't being maxed out and everything's going well. But can you manage the room? Can you manage the patient during a complication? And it's also leadership. When you are in the operating room as a surgeon, you're the captain of the ship. So where does that fall when you graduate and you become an attending? And really what we have seen across, again, all subspecialties, that there's declining confidence across OBGYN and general surgery and just core procedures. So obviously as procedures get more complex, the confidence is going to go down, but even in the core procedures, the confidence is decreasing across the board. The majority of general surgery residents at this time are pursuing fellowship. And one of the main reasons for this is that they're not ready, they're not confident enough to actually go out into independent practice after. And only about, depending on which study that you read, about a third of graduating residents feel ready to start practice on their own as an attending surgeon. So it's, as you can see, not just about surgical skill, but it's about all these other areas that we're trying to prepare our residents for, or our fellows for. Then you think back, like in my day, right? Like I think about this, all of a sudden I'm like the guy that's like, in my day, and I'm like embarrassed to think about it, but like truly, I'm like, in my day, we like read textbooks. Like in my day, like I wanted to stay late for the case. Like it feels different. All of a sudden I'm thinking these things. And there was a really interesting article put out by ACS looking at older and younger surgeons with a survey study, under 45 and older than 45. And the commentary at the end was like very enlightening for me, just seeing the different perspectives of how training looks today in regard to all the different competing factors. And within that realm, there are a lot of complex factors at play. So it's not just one thing that's impacting our readiness of our trainees. So it's duty hour restrictions. We know about this. Some of us trained before they went into effect, some of us after. Declining case volume per resident. So in general, within OBGYN, I can talk about hysterectomies. There are like a million ways to do hyst these days. There's like open and straight stick laparoscopy and single port and robotic and vaginal and open, like all these different ways. When before maybe there was just one route, and now we have like many routes at the same procedure. There's decreasing graduated autonomy in the operating room, and we'll talk about reasons why that may be in the next few slides. There's increasing case complexity. So we're getting better at medical management and non-surgical management. So when we have to bring patients to the operating room, they're much more complex. There's a medical legal risk, and there's some misalignment of training goals and actual clinical demands. So in short, the environment has changed, but our training models at large haven't kept pace. They haven't changed along with us, which is a problem. So from a surgical trainee standpoint, there's lots of perspective here that I think is really important. So our surgical trainees, they work so hard. My residents and the fellows that I work with work so hard. But things that they're facing are a high stress environment, right? So they're doing oftentimes high stakes procedures, constant pressure to perform, right? They want to do really well so they can keep doing the case as hopefully primary surgeon. They're often working with multiple staff with limited continuity, at least at my program and at many programs that I speak with, in that they have random attendings, maybe multiple times during that week, and it's hard to build that continuity. Another aspect that comes up a lot is limited feedback, right? And I know we hear this a lot. Sometimes you have to be like, okay, I'm now giving you feedback to make sure they understand we're giving feedback. That's true, but it's still sporadic. It can be generalized, right? Like the most useless feedback is like good hands. Like what does that actually mean? So some of the feedback that we give actually isn't very high impact. And again, lack of continuity between evaluators. And there's different platforms out there. We use my tip report at the clinic, which can be helpful because you can see what other attending surgeons have evaluated each resident on. So it helps you know their baseline, but it can be difficult to have continuity between that. And there's lots of skill development gaps. So mastering complex techniques can be hard with all the limitations we just talked about. And also mastering non-technical skills, like the space in between the technical skills. So communication, decision-making. Like again, when your bandwidth is maxed out with maybe a team you're not ready, that you're not usually working with, what happens to the technical part of your hands at that point? So lots of challenges by our trainees. But man, as surgical educators, we're also trying real hard. Like a lot of us are really invested and also facing some challenges. And things that we think about, Ted Anderson at Vanderbilt, another one of my mentors, told me this, and it has stuck in my brain, and it somehow makes me feel so seen. So he told me that as a surgeon, there's three aspects of your life. Yeah, there's efficiency, there's education, and there's patient safety. And he told me, he's like, King, pick two. Like you can pick whatever two that you want, but you can't have all three. And granted, this is not black and white, right? There's gray. You may have a very elevated fellow that you can pick all three, but in general, you can pick two. So if you're going to be really efficient and you want to value patient safety, meaning patient safety is number one, which should always be one of the two, I would recommend and suggest, education may take the back seat. If you're efficient, or if you're educating and valuing patient safety, you're going to be a little bit slower, right? Like just nature of the beast, you're going to be a little bit slower. If you're efficient and educating, patient safety may not make the cut, which is again frowned upon in our profession, seeing that patients are our true north. So again, we're also facing a ton of challenges within our realm of education as well. And so I think about how are we currently looking at our learners, and I really think that milestones are not enough. These milestones, in my opinion, are so limited. And I understand they're important and they give us some perspective on our learners, but they're just not enough. We can do so much better. Competency does not equal confidence, right? They're very, very different. Technical skills do not equal independent readiness for all the reasons that we just spoke about. Simulation, exceptionally important. We have a body donation program at the clinic, which is unheard of. So we have free cadaver labs whenever we want. So like our simulations are top notch and incredible. But at the same time, that's not always enough to get our learners where we want them. And again, tons of feedback gaps. So I really think it's important that we help residents understand their own decision making and identify themselves as surgeons, and not just complete a case log, or push milestones for their attendings to fill out. And so within that realm of feedback gaps, this isn't just for learners, right? We're giving feedback to our learners when they're with us, or when we're learners, we had feedback. But what we're seeing is once you graduate, right, you want to keep on that trajectory. You want to keep innovating. You want to keep fine tuning your skills. You want to keep moving in that direction. But oftentimes we plateau. And why does that happen? This area of feedback. Like so many times we get in the grind and we just start being in our silo and working and operating. And without that space of feedback, it actually really hinders our future progress. And so that two-way conversation about getting below the line of the whys of our practice are critical at forward motion for even when we're out in real life. So again, performance improvement, which we spoke about briefly as a surgeon, different buckets. This is really superficial, but when we talk about coaching relationships, so a coach and a coachee, these are kind of the big boxes that we think about. And this is the lens I think about with my learners as I'm assessing their quote unquote readiness for graduation. So technical skills, exceptionally important. Psychomotor, exposure, approach, use of both hands synergistically, all those things are important. But I also want to know about cognitive skills, decision-making, judgment, situational awareness, and how am I actually evaluating those things? And how am I pushing them to the limit to be able to evaluate those things in a safe and supportive space? I want to look at self-regulation. So what are my learners doing in regard to stress response, coping strategies, interpersonal skills as well, right? So how is my resident or fellow communicating with anesthesia? How are they communicating with the scrub tech? What is their leadership in the OR? Do they have a presence in the OR? Are they making people feel like they're being seen and brought up with them? Or are they talking down to their team and teamwork? And these other areas are very hard to evaluate in the current system that we have with residency and fellowship, I would argue. And so this is the space where I think surgical coaching in general can really supplement our current trainees and really bring us to the next level. Not that teaching is not important. Teaching is exceptionally important, obviously, but it feels much different than coaching where there's a flattened hierarchy, meeting your learner where they are and helping raise them up to their ideal state and closing that gap. And so what studies have shown is that this space that we're talking about with interop decision making, failure to regress, right? Like sometimes you watch your own videos, if you watch your own videos, and I'll see myself doing lots of movement, but like nothing's actually happening. And I'll be like, what did I just do for 10 minutes? Like, did anything even happen? I swear to God, I was working, but nothing actually happened. And having a two-way conversation around that space, that's where real progress is made. And so I think it's really a really beautiful, sweet space of being able to have these conversations with our learners and tapping into these areas that truly make somebody ready for independent practice before they're out putting their signposts up for being a surgeon. So in regard to surgical coaching, what does it look like, right? So surgeon coach, and this could be anyone, right? So with our peer coaching model, it's a flattened hierarchy. This can be resident to resident, This could be fellow to resident. This could be attending to attending. It's really a flattened hierarchy where the coach holds the space, brings their coachee through these different areas of goal setting in regard to what does the trainee think is the goal for them, helping them tap into their, if you're using video-based coaching, which is one of the main ways that we like to do coaching, asking the right questions, giving the right feedback, and having an action plan. And then going through those 4 buckets of performance coaching. This is the space that actually will get somebody to the level of being ready to get out and work. And I think as case volume is going down for many of us, there's such a ripe area to maximize the impact of every case. Like right now, when my learner comes to me, my OR, the hysterectomy is 90 minutes. Okay, fine. That is such a small part of where the learning can happen that if we can capitalize in every single case. So after the case, take the video, sit down for a coaching session. That will truly change someone's perspective in a way that you can't get during the case. So instead of just looking at, oh, my case numbers are going down, or we have limited duty hours, they're just not exposing themselves enough to the pathology at hand. I think there's a space here to actually maximize the cases that we're doing on a whole entire new level. And so my previous fellow Morgan Orlando and this team, we published this in AJOG a couple of years ago about how to actually build surgical coaching into obstetrics and gynecology. It can be in any subspecialty though, and really the evidence-based way to do that. So if you're interested in that, this could be a great resource. So with that being said, I think call to action. I think this is the time to change the culture of educating our learners, change the culture of how we as staff continue to excel. I think we need to reframe readiness. So coaching, again, is a longitudinal investment in our residents, our fellows, and in ourselves and in our partners. It's a shift from training to meet a milestone to coaching actually towards independence and being ready to practice. And it's not a remediation. This is such a key part of what we represent, is that this is not a space for punitive action. It's a space for true professional development. And we need to model that too as surgeons. So as a surgeon, I am a coachee, I have a coach, and I think modeling that to our learners is also really, really important. So what can we do? I think we need to work on embedding coaching in resident and fellowship training. I don't mean adding on. I mean actually replacing things that aren't working. So maybe you take a grand rounds once a month and make that surgical coaching for 60 minutes, right? So actually building it in. So not being something, oh, extra, but actually a requirement for your learners to graduate. Also advocating for institutional support and protected time. If you need help doing that, contact any of us at the Academy. We have great literature showing how it helps physician retention, how it helps save money at your organization. Money talks. We can help with all of that if you are working towards that at your institution, as well as reframing coaching as really the bridge between training and thriving. So in this time of crisis, the future is not dark. We just have to shift, pivot, be creative, and really embrace a new way of looking at training. And honestly, it's so rewarding for both sides, both the coach and the coachee. So with that, thank you so much. Appreciate your time. I'd love to hear your feedback in the chat for sure.
Thank you, Dr. King, for those valuable insights on bridging the gap between training and independent practice. Your presentation really highlighted the crucial role coaching can play in preparing the next generation of surgeons. So thank you very much. We will now move on to a discussion exploring how we can utilize data to facilitate surgical performance improvement. For this segment, I'd like to introduce our panel of industry leaders. Anya Bradfield is the Director of Product Management at Care Syntax, where she oversees product strategy and the development of innovative solutions for a healthcare SaaS startup focused on the surgical care continuum. Diana Gilogli is a Solutions Executive Director at LeanTAS, helping hospitals successfully incorporate new technologies with workflows to optimize operating room capacity. Thomas Knox is a founder and CEO of Vitvio, which focuses on bringing ambient sensing and AI agents to the operating room to drive better hospital ROI and patient outcomes. Charlie Robbins is a vice president of sales for Proximie, which empowers medical device companies and healthcare organizations with real-time connectivity to drive productivity and innovation across the perioperative life cycle. And finally, Tamir Wolf, who is co-founder and CEO of Theater, which uses AI and computer vision to analyze surgical videos, improve surgical outcomes, and reduce variability in surgical care. Moderating this industry panel is Dr. Caprice Greenberg, joined by Dr. Kara King. Dr. Greenberg serves as chair of the Department of Surgery at the University of North Carolina, Chapel Hill, and is co-founder and president emeritus of the Academy for Surgical Coaching. Dr. Greenberg, please take it away.
Great. Well, I am so excited to be here and to be talking about this. I think this intersection between data collection and how we use data to improve performance is something that I think we often don't think enough about. We sort of have our people that are over here in the quantitative world collecting data, and then we have these people over here in the QI world that are working on performance improvement. And I think that the greatest advances happen when we can sort of bring them together. And so I think it would be helpful maybe to start our panel if we just did a quick round robin, and each of you just gave us a little introduction. I mean, each of you are here because your companies facilitate data collection in some way, and you recognize the value that it brings to performance improvement. And I think that that is really a unique mindset and space that each of you are in. So it would be wonderful to hear from you sort of what some of the data points are that you collect, and then how you sort of envision people using that data to improve the ways that they deliver care. And I know each one of us can talk on this probably for an hour. So I'm going to ask each of you to keep your opening comments to maybe 2 or 3 minutes, just so that we can really get into an interactive discussion around these things that I think we all care really deeply and passionately about. So maybe, Tamir, I'll ask you to kick us off.
All right. Hey, everyone. Thanks for having me. And listening to you guys, I think coaching is an amazing space, and I think that the basis for it all, when we're talking about data, is acceptance of transparency and trust. I think that's the basis for it all, and so data is so crucial because having the data allows the objectivity on which you can start forming. That's basically the foundation for transparency and trust, and the ability to interact on like what in our world we call the ground truth, which is what actually happened, not a recollection, not someone's subjective thoughts about it. So I think data is extremely important, and I think we have like multiple participants here on the panel that gather data from various aspects of the operating room. When I think about the data coming out of the operating room, it could be around team dynamics and instrument utilization and everything that's going on in the room. There is the data coming from the procedure itself, which is what we're focusing on in theater, the intracorporeal procedural aspects, analyzing what's actually being done in the procedure that can lend it a lot of value to understanding of what we're doing well, what we're not doing that well, and how to improve. And I think for the first time allows us to gather real world data, real world evidence on which to base a lot of the initiatives afterwards when we're not operating and when we're thinking about helping ourselves improve and helping those around us improve as well. So just a few opening comments. Thanks again for having me here.
Great. I love that. So what I heard from you was sort of that importance of objectivity and sort of, defining sort of a baseline ground truth and understanding what's really happening. That's really fantastic. Well, Charlie, you move up in the list.
There we go. Similar to Tamer, I think what the point of it is the objectivity, and what we're doing is providing that objectivity, but in a more comprehensive view. You guys are used to having bits and pieces of data, and so what we're trying to do is pull together an objective view of a comprehensive view of a really complex space that's a high stress environment, and to allow those people to learn pre, post, during, not just in the high stress environment, but recording cases that are meaningful and important to see, not only just the intercorporeal views or the room views or the workflow views, but all those things tied together to see, hey, what actually happened, but in a meaningful contextual way that you can review anytime, asynchronously, when it's on your own time, less stressful, and have those fewer cases, as Dr. King was talking about, be more valuable, because you could go back and say over and over again, hey, I'm looking at this piece this time, and maybe the coaching, this aspect is what we're going to focus on for next time. So really kind of bringing that all to a unified data set and providing a lot of context of a very complex environment that in the moment you probably will miss some parts of it, and bring that objectivity to it. So thanks again for having me.
Awesome. I love that. Okay, so that was Proximy. And then Anya, do you want to tell us about care syntax?
Sure. Thank you for having me. I think care syntax is founded really on OR integration. And if you think about that, it allows us to really capture a lot of the data in the OR, whether that's the intracorporeal video, the extracorporeal video, whether that's the anesthesia data, instrumentation usage, which allows us a really unique perspective to build a holistic view of what happens. But more important, to Tamir's point, is capturing all of those decisions that precede surgery, right? Like what clinic visits, what radiology diagnostic tests were done, and how can we really improve that total continuum? And so that's where we're actually expanding into getting some of that preoperative data as well as the post-op outcomes to truly assess, to give you more data to objectively identify not only did the procedure go well technically, but ultimately, did we impact patient care? Did we improve value-based care? And so that's where we think, again, data really drives that to bring objectivity to the process.
Great. And I think, most of the first three platforms, I think I've worked with all of you and know that all of you integrate video into what you do and how you utilize data. I think, Diana, you guys are even deeper into sort of the data analytics piece. So what do you guys do, and how do you think about that in terms of how we should be thinking about using data to improve performance?
Yeah, thank you for having me. I think one of my favorite sayings, and it's not mine, but now I've adopted it. I heard it from the chair of anesthesia at Loma Linda, talking about moving from just a world that felt like a lot of drip, being very data rich and insight poor. And that's really the world that we try to live in. We work really closely. We have, either through acquisition or partnerships, work very closely with folks who are collecting data at various points. And really the procedural and OR space and moving upstream, doing a lot with pre-anesthesia testing and patient optimization, but really trying to drive surgeon engagement as well. Because one of the things that I found working really closely with our partner organizations, if you don't have surgeons at the table and they're just looking at data once a month, you're not improving block utilization, you're not improving prime time utilization, you're not doing anything for identifying why cancellations are happening. And so really driving insights to the right folks. And I think maybe Charlie, it was you that touched on it, having transparency and visibility, Tamir started it, is really key, but you have to be able to send data to folks in a way that makes sense for their roles. And one of the things we do really well is we level set on data definitions. What is a first case on time start? If you're including flip rooms, then let's include them for everyone. So we're all looking at the same data. We're using the same definition. I think some of the most strong improvements I've seen, I worked really closely with an acute service line leader who single-handedly, just by being able to see data, what happened yesterday, today in front of him, said, you know what our problem is? Patient transport. All of my inpatients are late. And, you had a lot of operational leaders on the call who were looking at it and weren't identifying that, but it was a pain point that surgeon felt in real time. The data backed up what the surgeon was feeling. And I think the more that we can drive these kinds of conversations where surgeons are empowered to engage without having to live in data once a month at an operational meeting, we'll really start to see better outcomes, better capacity management, better patient outcomes, and better patient optimization prior to even entering your OR suites or procedural areas.
Great. So, as I listen to each of you guys talk, like this is a no-brainer, right? Like we talked about the fact that we have all this data, we don't really have information. Like we've talked about, all sorts of different data from what's happening in the OR table to what's happening in the OR to how we're managing our block time to preoperative decision-making. So my question for you all is like, I've been trying to do this since 2001. Like, all right, I've been at this now for 24 years. And like every 5 years or so, like I reflect back and I'm like, gosh, like I thought we'd be further along by now. What do you see as sort of the biggest barriers that we run up against into adoption of the types of things that we're talking about, which is, basically, right, data-driven performance improvement. It's getting the data, it's using things like coaching. Like why isn't everybody doing this? Charlie, I saw you come off mute.
I think a lot of it is twofold. It's inertia. It's just doing things you've always done because you've always done them that way. But I think the undercurrent that we have to uncover in a safe way is a little bit of fear, right?
Mm.
Is what is putting cameras or collecting all my case data in one place, showing the room how I treat people or interact with staff for my workflow, for my trainee, what does that mean to me? How does that reflect on me as the educator? So I think a lot of it is just kind of moving people towards a place from fear to, hey, this is actually a better thing, and nobody's trying to get you. It's more just trying to help everybody improve and not just, point fingers and blame people for things.
Yeah, I love that. So how do we make sure that this is always being framed in a constructive way?
That's right. Yep.
This isn't Big Brother coming in.
That's correct.
Okay, so I'd love that fear piece. What are some of the other things that you guys have encountered as you've been interacting with a number of different institutions and surgeons and environments?
I can take a stab. In my previous life before Lean-TAS, I worked in patient-reported outcomes, data collection, and I think some of the chat brought it up. Like, hey, if you're coaching, you're not hitting your RVUs potentially. If you're spending a lot of time kind of bringing up the next great leaders in surgical services who are taking care of patients, and so I really think that the tools we have to work with the daily lives of surgeons. I'm married to an orthopedic surgeon. He doesn't have time to come home without me complaining and spend a ton of time data diving and becoming an expert. So I think that we really owe it, all of us that are in industry, we really owe it to to our customers, the people who are taking care of patients, to impact healthcare in a way that brings tools to the table that allow you to do the magic that you do with your patients, and do it in your world where you're not then spending another full-time job engaging with data to drive change and to coach folks. So not only does it have to be safe, like Charlie spoke about, but it has to work into the workflows that you already have, and hopefully even improve them. And by improve them, I mean reduce some of the administrative tasks that take our healthcare providers down a level, so that you're working at the top of your license and you're not doing a lot of administrative tasks, whether that's clicking boxes in an EHR. And I think the elephant in the room, if somebody's thought of it, Epic's going to do it eventually. And so that's a big challenge for a lot of innovations, and that I encounter is running into hospital executives, CIOs who have spent so much money on an EHR that they're really reticent to pull in another technology, because maybe this huge expensive system will eventually come up with innovations that will match some of the more innovative things that are out there in the market.
No, I think you touched on a number of really important things. I think the thing that you spoke about that resonated the most with me was time, right? And the fact that, again, my biggest concern is with the financial pressures that we are all facing in healthcare right now. Nobody's really thinking about the decision, like the future implications of the fact that nobody has time to teach, nobody has time to innovate, nobody has time to think about quality, and all of these things that we used to be able to do are being pushed out by the need for clinical throughput. And we're all going to wake up 10 years from now and wonder what were some of those decisions that we made. Tamir, did you want to comment? Or
So I agree with everything that was said. I think culture is the main barrier. I've seen this field obviously evolve over the past several years. Initially, the conversations were, why should I, routinely capture my procedures? And it very quickly, I think, or slowly, over the past several years, has turned into, okay, what is the ROI that we can demonstrate by doing this? I think so. There are two components. One is, the cultural elements, especially in surgery, which is very siloed. And like one of the amazing things that I think you're trying to do with coaching, and we're trying to do with data, is to just break down those silos and enhance transparency, etc. So that's one component. The other aspect of this, okay, how do we demonstrate ROI? And how do we demonstrate ROI around improving quality, improving safety, enhancing operational efficiency? How do we demonstrate ROI with coaching? I think that's a huge element in and of itself. And I think the key to from perspective of someone who's bringing in technology, that's like something that I guess all of us on this panel are grappling with, because we need to convince healthcare system leaders that, obviously the surgeons and the most innovative ones are obviously bought in, but how do we convince the folks who are holding the purse strings to bring this in? The value that we can provide is substantial, but especially when deployed at scale. So that ROI question is something that's like top of mind for everyone, especially within our healthcare system today. And so a lot of the effort that we're doing is to work together with our partners. Like it's the way all of us here work together with our partners in healthcare systems and physicians and surgeons in order to be able to show demonstrable ROI that will help us then get this in. But those two aspects, culture and ROI, I think are huge.
Yes, I will say those are two things that I am personally dealing with right now, and I think I think all of us are. And so I do sort of implore everyone on this call, as you do sort of make strides towards that ROI, publishing it is so important, because being able to bring those use cases back and being able to show, I saw Kara put in here, the Becker's report about how Cleveland Clinic saved $130 million with coaching. Being able to bring those cases forward really do help to make the argument. So Thomas, thank you so much. I'm sorry you had technical difficulties.
I'm so sorry about that. It's like the perfect storm, right when you're trying to join in on something, the internet goes out, and I'm like, I have to try every single way to get back on. But thank you so much.
Well, we're glad you're here. I know you've just sort of joined the conversation. If you have anything that you want to add, otherwise I was gonna let Anya have a chance to speak, and then we can come back to you as you figure out kind of where we are in the conversation.
Maybe just to touch on one little thing that Tamir was highlighting here is, kind of the ROI of the hospital. Maybe you guys touched on this a little bit, but one of the things that I really think is amazing right now is it feels like there's been a fundamental shift in just the perception from hospitals globally, and that there's kind of a, like right now, this is inevitable. It's going to happen. These kind of technologies are coming. Now, which ones are the ones that are actually going to make a difference, and which ones are vaporware? And it's like they're trying to, it seems like every hospital system has now acknowledged that this is where it is going, and that we all have to lean into this. It's just now like, let's see where the real value is at,
I hope that's true.
Yeah. We still have a lot of ways to go. I'm not saying we're there yet, but it does feel like it's a lot more, let's say, people are a lot more open to it than even 2 years ago. You know what I mean?
No, I think that's exactly right. I think every year it gets a little bit easier. There's a little bit more conversation. There's a little bit more openness to it.
Exactly.
I think that's absolutely right.
Maybe one more thing that I'll add is, for surgeons, this concept of gestalt, of gut feeling, is something that's like ingrained, maybe in like old school, less so in like, current and like the next generations. And this is where data really has impact. And I can share that several years ago I had cancer, and I went to the guy who wrote the textbook on what to do to me, and like I woke up 8.5 hours later and I asked him, all right, so what did you do? And he told me, and I'm like, what? Yeah, I had this gut feeling. I'm like, this isn't what you published on, wrote about extensively, and like all the guidelines are like based on this. Yeah, I had a gut feeling. And sometimes that gut feeling is great, but I think when we let it lead, there's something that's fundamentally like not 100% with that. So I think the foundations really need to be about data, and like we believe that, like, this is a tagline. I'm not a marketing person, but a tagline I fell in love with was like data beats intuition. I think there's like a huge need for data as the baseline, real world evidence based baseline, and on top of that, you can obviously put that intuition or the years of experience that you've had. But especially when folks are starting out, they don't have that. They don't have that gestalt. They don't have that gut feeling. It's something that you acquire. You guys know this, better than us. You acquire it with time, with experience. And so there needs to be some common ground, some foundation. And then I think through experience, through coaching, you can, be able to modify that foundational data and evidence-based layer, but it can't all be, gestalt or gut feeling.
Yeah. And I think many of us would say it can't all be data either. So it's exactly, in my mind, that's the beauty of talking about, analytics and coaching in the same sort of conversation, is that you're bringing both of those sides together. The coach is sort of challenging you to look at your data, figure out where you are, and then, sort of have that more qualitative conversation about how do you change, how do you have that accountability.
I love that. The key is to having access to that data. And I think and to that objective ground truth, which I think is what everyone here is pushing towards the future where that's really available.
I think the other piece of it is, we talked a lot about how busy all surgeons are, right? But we're all really competitive. And so if you give somebody data that somehow places them relative to their peers and give them some idea of where they're starting, I have found that to be a huge motivator for people to be willing to participate in coaching in a way that they might not if they didn't sort of have that understanding of where they were and what was possible by looking at other people's performance, right? Again, I think sometimes I loved, Kara, you shared one of my favorite diagrams with that sort of plateau that we have when we stop deliberate practice, we stop looking at what we're doing, we stop getting feedback. And so, again, without that data to know where we are, and then that feedback to sort of move up on that curve, we're all sort of languishing.
But I would also add something to this, which is, there's such a thing as cognitive overload. There's already so many things that the surgical teams are balancing, surgeons themselves are balancing. And I think, right as I joined, you brought up a really good point of like, if we can implement technologies that get the staff, or surgeons, surgical staff, et cetera, all focused on the patient and focused on that quality of care, I think by natural, it will just improve over time as well, because you have fewer things that you're balancing when you have like less administration, you're working at the top of your license, and you're really, your core job and only thing you have to focus on is patient care. That's right there where like you take that data and you take that intuition and you take that time and you combine those things together, or that focus, I guess, maybe not necessarily time. I always think we'll find a way to fill the time, but you take that focus on the patient and try to remove some of that administration that's behind it. And I really think that comes together to paint something really beautiful for the future.
Yeah. The other thing I think that again, the data and the video both allow us to do is to be able to understand where there's variation in the care that we're providing, and where that variation is really unnecessary. And when you get rid of that, and it's not about, oh, this is what, surgeon A likes this suture, surgeon B likes this suture, it doesn't really matter. Like, let's just sort of come up with some basic things and then take that off the table so that we don't have that cognitive overload. I think there's tremendous data to suggest that that's important. But again, we don't even have the tools necessarily to be having those conversations about what people are doing that is variable. And that's where I think some of this video review can be so important. Diana?
Yeah, I was just going to say, we push out a cost per case analysis to surgeons, and it is empowering for the surgeons. I mean, it's almost like a Netflix, no judgment. I come from a world of orthopedics. When I ran ORs, I would much prefer somebody use Smith & Nephew than Arthrex, because it was because of cost, right? But and one of my favorite stories from what we're pushing out at Lean Toss to surgeons get a list of what they use, to your point, benchmarked against what other folks are using. And we had a surgeon come back and say, well, this $400 thing is in my tray every time, so I use it because it's there, but it doesn't affect my outcomes. I'm happy to give it up. So being able to give surgeons information without them having to go seek it out, find it, spend more time getting it, is really key, I think, to moving things more toward kind of an approach where people are at least aware of what other folks are using and getting great outcomes using, and having those kinds of conversations.
Yeah, no, I love that. I think that sometimes there's this narrative with hospital administrators that, physicians don't care about cost. And I would argue that it's actually that we just don't have any data or any information to have any idea about what we're doing and how we could do it more cost effectively. And so I think there's just so much that can be done as we work together in this space. Dr. King, you've been awful quiet as my co-moderator. What are your thoughts?
I'm feeling very pumped up. I'm feeling really pumped up. We could talk for like 2 hours on this, right? And I'm hearing so much importance around like culture building. I'm hearing a lot about like, you're right. We like data, but we are competitive. But if we don't have a place, like a sustainable way to actually take our data and elevate ourselves, like through something like coaching, then it just can feel frustrating versus empowering. So I think that conversation around the data is exactly where we're all falling. but I'm thinking about like next frontier. Yeah. Like next frontier, we're getting all this data. I'm curious, Anya, what do you think about like, how do you shake out what data actually matters? And I'm curious, what's coming? Like what's coming down the pike that we don't even know is coming yet?
And I'll give you our perspective on shaking out what matters, because you guys all know there's so much data in healthcare, right? And the vast majority of it's not used or not useful or locked away in unstructured formats like physician notes. And so capturing that data, right, is going to be really, really important. And using technology via AI for, again, video-based algorithms, whether it's natural language processing, optical character recognition, whatever that may be, ultimately allows us to structure some of that unstructured data and really pull out insights. So using an example from something we've done with one of our customers, going to cost and quality, right? Many of you are familiar with the ability to lower the insufflation pressure for laparoscopic and robotic procedures. And so seeing that tied to a reduction in length of stay, better pain management for patients, ultimately allows you to really dive into that value-based care, how a technique or an approach or a clinical decision preoperatively allows you guys to better manage the patient care and improve over time. But I really think in the future, coaching is a standard part. And I think, Dr. King, you alluded to this, as a really standard part of residency. I could see portfolios being built, right, to evaluate surgeons in the future when you're doing potentially hiring. But ultimately, I think everything is an iterative cycle. It's not a one and done solution for any improvement, because you will plateau. So I think technology will help, but I ultimately feel like it still has that human element, to the point to improve decision-making, to challenge also as well constructively all of our biases.
All right.
Great.
I love that.
That was perfect. And I think, Thomas, I'd love to hear from you about your vision for the future and your new frontiers.
Yeah, I mean, ultimately, my vision for the future, like if I had to give a tagline, and I know that there's other in the room that are working very specifically on like, targeting the coaching aspect. We're at Vitvia, what we focus really on is, if I had to give a tagline, it was like get the staff, get the clinicians focused on the patient, we'll do the rest. That's really our main goal here, is to take over that kind of administrative burden. Where I see the future going is like the way that our system works, we have like multi-camera deployments within a single room, so we can basically digitalize the OR into 3D. And where I really see this is that we're going to move into a stage where it's not just information or video that tells you like, hey, here's what we could have done better during the surgery, but you get a really truly immersive experience, where basically you could put on VR goggles and walk into the operating room and watch the surgery be reperformed live while you're standing there with a full 3D reconstruction. I don't just mean like a 360 camera where you can like look around, but I mean you can actually walk around the room and discuss a case while you're watching that surgery ongoing, while also having things like the laparoscopic endoscopic camera view being projected in front of you where you can move it around. I think that this is going to get a lot more holistic, and you start to pull in multiple data, like let's say, different types of sensors and inputs, and really reconstruct that environment. So when something doesn't necessarily go right, you get to be right back in the moment again and discuss it, because there's a lot of nuance that I think that gets lost in the way that we coach today. And I think that that's where it's going to be headed to. I'm not saying that that's there today. I'm not saying that, this is even 1 year away, but I think that this is something that we're very quickly moving up on in a pace that I don't think people realize just yet. I think there's going to be some really big innovations that come out in the next year or two that are going to be focused around getting coaching and getting like surgical training to that level.
Yeah, I love that. And it also feeds into some of the data around visualization and sort of different approaches to preparing as well. All right, Charlie, we're going to give you last word. What do you have for us? What were you looking for in the future?
I think what we're kind of focused on is there's a world that we know today that's coming at us quickly, and there's a world that we don't even know exists, and that's not 10 years from now, it's not even 5 years from now, it's like 12, 18 months away. And so what we're trying to do is make sure that we're curating today. So obviously providing a foundation that can kind of future-proof what's coming, and work with colleagues on the phone and people like yourselves to say, none of us are going to have all the answers, but how do we structure and curate a platform or technologies that we're building today, so that when things come along, we're more additive to the ecosystem, not trying to be isolationists so much, where maybe in the past the company would just run and hide and say, here's our IP and we're going to tuck it away. I think we're all looking at the future of, we're going to have to all work together, especially to deliver for people on the phone, of less clicks, more integration, less time spent doing one platform than another, than another, than another. It's how do we focus and deliver value in what we're doing, but also be able to hook into, an EHR, they're not going anywhere. Some of those other things that are fundamental to your day-to-day and be additive to the ecosystem, not trying to be isolationist in it.
I love that. I think many of the people on this call are all about collaboration. So I love that idea of an ecosystem where we can collaborate, where, we're looking at efficiency and really trying to optimize performance. That is a fabulous vision to end on. So thank you all so much. I think this has been a really fantastic panel, and I'm going to turn it back over to our hostess, Sudha.
Thank you so much to our panelists and Dr. Greenberg and Dr. King for this really enlightening discussion on the integration of data and coaching. Your insights are undoubtedly going to help shape how we approach performance improvement in surgical practice, I think, moving forward. So shifting gears a little bit, as we navigate change in our professional lives, making informed decisions about career transitions becomes increasingly important. Our next speaker, Dr. Christine Lombardozzi, will guide us through this process. Dr. Lombardozzi serves as the chair of surgery at Edward Via College of Osteopathic Medicine in South Carolina and is a surgical director at the Academy for Surgical Coaching. Dr. Lombardozzi will lead an interactive exercise on considering career options, helping us recognize when it's time to make a change and how to structure our thinking around next steps. Christine, please take it away.
Thank you very much. That was such a lively discussion. I'm hoping that I can keep that momentum rolling here with giving you an idea of how we can use coaching to leverage what we know the benefit of coaching around these conversations that are they happen to every surgeon. And so to start this off, I don't know how many people have used whiteboard before, but as we get going, there's a way for you to pick up a sticky note and contribute to the conversation. I want this to be as interactive as possible. So to start with, I just want to put a little foundational material up in front of you, understanding, to the screen right, the framework of a coaching conversation, which has been in the slides in Kara's talk, and really just demonstrates the arc of how a coaching conversation goes. Then I'll point yourself towards the 5 stages of change. This is important because understanding that contemplation or thinking about change is a part of the continuum of change, but where it really doesn't become action-based until we get into preparation and action. And this is where coaching can really help move people forward from and through contemplation, through their preparation and into action. And then finally, I want to point out this cognitive behavioral thought model. This is a very useful model of understanding sort of our own personal reactions to the events that happen around us in any part of our life, and understanding that the situation is actually neutral. The thoughts we have about that situation actually generate how we feel about it, and that feeling actually underpins our behavior. And so this is foundational as we start to understand how we're going to manage our thoughts around some of these really crucial changes. All right, now to slide 2 here. I would love for people in the group here, pick up a sticky note and tell me, why do surgeons consider or execute career changes? Any ideas, any thoughts about why we might choose to leave where we are? Work-life balance and burnout, absolutely. And we find that can actually happen at any point inside a surgical career, not just the older or the mid-career. I see physical demands and call difficulty. Very important, especially as we are dealing with our bodies and our practices as we age. I'm seeing the ability to grow, compensation, work-life balance. And I would think our definition of work-life balance changes as our careers and our lives evolve through our different stages of what our priorities are going to be. Let's see, frustration with leadership. Absolutely, as our leadership changes, or as our, did the whiteboard just disappear for everybody? Let's see.
I think I did that to you, Christine. I'm so sorry.
No worries. Okay. This is,
When people in their 50s try to use new technology.
I'm right there with you. Yes. I think, yeah, so I'm seeking greater professional fulfillment. I think as we evolve, especially as we start to hear, there is something magic about year 5 to 7, as our work becomes less new, less challenging, that we may want to reevaluate what we're doing, how we're doing it, where we're doing it. I'm seeing, I'm going to drop in this one, misalignment of goals and vision. As again, depending on the structure in which you're practicing, what is your leadership? What is the hospital? What is the hospital priorities? Are those changing? More time with family, a plateau in ability to grow. These are the common themes that underpin career changes for, I would say every professional, but I'm gonna limit it to our surgeon discussion here. I've got one here I want to pull up. Conflicts within the practice. This is actually a big driver. Either conflicts within your practice or conflicts with your colleagues. And I put that forth because there's some of this that we can control and there's some of this that we can't. And how do we move forward? I see in the chat disillusionment with a surgical mentor as we grow and perhaps the relationship with the people who have supported us and guided us change. And I think I'm looking to see if I have any other ones that I think are, let's see, spending more time with family. I think we can see that ebb and flow, have a young family, or quite frankly, get into the sandwich generation where your young family is on their way, but their older generations are now revisiting us. So here is the thought work or the contemplation that we go through as we consider or decide that, hey, I'm not as fulfilled, or I am not in the place that I assumed I was going to be at this point in my career. Now, how are we going to move forward? So let's move on. So the next part, if we've moved through contemplation, so this is where I'm going to offer that having a coach can be extraordinarily useful, because I can think all these thoughts and I can have all of these sort of desires or dissatisfactions, but how do we move through them? What do we need to understand about ourselves before we consider career transition? Does anyone want to volunteer something that you think would be important to understand about yourself? I'm going to ask you a question that I ask a lot of my coachees is, who's in your thinking? Who's on your team? This is not a change for an individual person. This is a shift for your entire ecosystem. And so who's on your team? So this could be your family. And as somebody brought up in the last one, your mentor. That might be a useful relationship, or quite frankly, it could be a reason or a motivation that you're wanting change. Your professional and personal, your professional trusted friends, personal colleagues. So you can start to build a network of whose opinions do I want to gather, including my own. Once we move through sort of who's on my team, I'm going to ask, how do we define what we can control? And I want you to look back and think about that thought model that I put up in that very first board. And so as we're looking, I see up here, managing my own thoughts and emotions, because change gives us feelings, and we have to understand how we want to think so that we can control and manage the feelings that we're having so that we can actually take the actions that serve us the best. And so I like to tell people this is just emotional adulthood and doing the work and the exploration that you need to do to be able to manage what's naturally going to come as you do this exploration. I would offer, let's see, what else do I have up here? I've got understanding your personal values, financial goals and timelines. I am a big fan of core values. I think until you have gone through the work of understanding what truly is important to you, what motivates you, what drives you, you may inadvertently move from one environment into another environment and still be at cross purposes. And so coaching can be very useful in exploring and defining and really getting you down to actionable and measurable core values. I think along the lines, as we're talking about personal values, is looking at your financial goals. What's your risk tolerance? Some of us are very risk adverse. Some are very movement forward and are willing to sort of take the down with the up. Where do you lie? Where are you on your work-life balance values? And I'm going to offer, this is probably something very worth going through. While core values don't tend to change over time, these personal values and priorities will change. And so I offer that this is something that needs to get revisited on a regular basis. I would also encourage, and I've got some stickies here, some core skill assessments. And I'd frame these up in those same quadrants of performance that we talk about with our performance coaching, is where am I? What are my technical expertise? Where's my cognitive abilities? Where do I shine? Where do I have gaps? How are my interpersonal skills? Do I have leadership skills? Do I have gaps with my leadership skills? How do I manage myself? How do I manage my team? And what are my self-regulatory abilities? This helps you understand where your opportunities for improvement before you even consider stepping into a new position. I have a couple stickies up here, and I think someone's moved them down here for this career capital. And so this is a little different than your skill capital, but looking at the other things you bring to the table. What is your clinical expertise and knowledge? Where are you a thought leader? Where have you developed your level of expertise? What's your research contribution? What's your academic standing? What are your personal and professional relationships? And what's your reputation? Does this ring true to people? Anything here that I'm missing that you think would need to be considered before we talk about changing positions? Because if you do this work and you understand these things about yourself, then it becomes far easier as we move to our next phase of taking action, which is really our coaching conversations around exploration and movement. And so what type of opportunities do you think you're going to explore when you're looking to change your career or change your practice opportunities? I can drop the easiest one on here, is you're going to look for a new clinical opportunity. Well, when you do that, how do you know what you want? And this is, Kara uses this sort of example when we're teaching in our coach training of, you have to know what your ideal is. Imagine your perfect state, and then you can start to understand gaps and how to assess and how to find out whether or not the new clinical opportunity that you're going to be looking at, how does it match up? When we're done here, we're going to drop a couple of resources into the chat. One of them is a great tool that came out of the Journal of Thoracic and Cardiovascular Surgery by Hamid and colleagues in 2025 here, that really gives a great framework of all the different components of a clinical opportunity to help you balance where you are and where you want to go. How about leadership opportunities? What sort of leadership opportunities might you be looking for as you explore a new career opportunity? How about departmental leadership? The idea that you may want to have an opportunity, you may want to change positions or change locations in order to have more opportunities to grow as a leader. Leadership doesn't have to be sort of limited to an academic environment with a departmental leadership structure, but we have opportunities to become leaders in our hospital systems. And there are certain systems that offer leadership opportunities that are not necessarily academic, but are more related to the administration of the hospital. Well, how do we prepare for those? Because again, understanding where your gaps are, we can prepare for leadership roles by taking specific leadership courses. And if you look at the leadership of our academic leadership, all of these organizations have leadership academies, leadership opportunities, courses that you can take. You could go and explore the opportunity to do an MBA or an executive healthcare MBA, and that will take you in a different direction. If we want to look at other ways of moving into a different career, we could consider some healthcare adjacent opportunities. We could be a consultant. We could move into bioinformatics, healthcare administration, the consultant, or the sort of side gigs, as people like to call them, of expert witness. And so again, what do you want to explore? How are you going to set specific, measurable, actionable, and time-restricted goals around each of these things that you want to explore? This is the arc of the coaching conversation, as we're starting to take action around changing careers. And so where does this leave us? So this leaves us with a summary of how we should move, or at least my vision of how we can move through career change with the best, sort of the best structure and the most success. And I just leave you with this summary. We have to understand ourselves and our motivations. We have to do our foundational work, explore our opportunities, and working however you choose to. I'm going to advocate that this is a wonderful way to work with a coach through setting goals, doing short-term actions or experiments, assessing your progress, and continuing that cycle until you come out on the other end with a plan that's really going to serve you. So I appreciate your attention and the opportunity to walk you through this exercise, and I'd love to hear from you, or reach out through the Academy. I would invite you to reach out. I'd love to have some more conversations with anyone who's interested.
Thank you so much, Christine, for leading that thought-provoking exercise. You introduced us to some valuable tools for evaluating and navigating career transitions, so thank you for that. So as we conclude our summit this evening, I'd like to highlight some of the valuable insights that were shared today by our presenters. But while I do this, if you could please scan the QR code on your screen and take a moment to complete the brief 3-question survey about today's summit, we'd really appreciate it. All of you who complete this survey will be entered into a raffle for a complimentary coaching session with Dr. Christine Lombardozzi. I'd like to once again express our sincere gratitude to our speakers and sponsors. Dr. Magdy Milad, who taught us how improv techniques can enhance surgical coaching through adaptive thinking. Dr. Kara King, who showed us strategies for accelerating practice readiness in new surgeons. Our industry panel moderators, Dr. Caprice Greenberg and Dr. King, and the representatives of Care Syntax, Leantas, Proximi, Vidvio, and Theater, who explored the powerful combination of data analytics and performance improvement. and Dr. Lombardozzi provided us with a framework for navigating career transitions. Our thanks again to Siemens Healthineers for their continued support. And finally, thank you to Veris for its support of this summit, with a special shout out to Dan Houghton. And thank you all for joining us today. We hope you leave with new insights and strategies for navigating change in your surgical careers. We invite you to join the surgical coaching movement by visiting our website and completing the contact form, or connecting with any of our Academy representatives to learn more about the work that we do. Thank you again and have a good night.